Good afternoon to Leipzig. A little after 4:30. Andre and Matthias, welcome to New York.
Yes, hello. Can you hear us?
Yep. Perfectly.
Very good. So hello to everybody, and thanks for letting us participate here. With me is Matthias Ulrich from our lab. And we can right away start with our first case. Maybe Matthias, you can introduce the case.
Of course, yes. So we have a male patient. Next slide, please. We have an occlusion of the right distal SFA artery. Clinical data, severe claudication, right more than left. Walking capacity is 80 meters. ABI right side is 0.4, left 0.5. He has an arterial hypertension. Next slide, please. This shows you the angiogram with the occlusion of the distal SFA, P1, P2 popliteal segment. However, it's a relatively small vessel and also a lot of calcium inside. Runoff, it's over 3 vessels below the knee. Next slide. We have a left crossover approach coming from the left groin. We want to go through the lesion, and just in case we would have failed, maybe we also prepared for going retrograde. And then we want to treat the lesion with a drug-coated balloon. And before we're doing this, we want to modify the vessel a little bit by using a scoring balloon. Maybe we can switch to the angiogram and we can show you what we have done so far.
Yeah. Thank you very much. Okay, so here once again
Andre, just
the SFA.
To let you know, we have a little technical hiccups here. No. You're getting the sound solved?
Yes, can you hear? I'm talking. Matthias, please talk.
Ich weiß nicht, worüber ich sprechen soll.
Can you hear us?
Okay.
No sound?
Andre, I think now
very
it looks like the connection is better.
Okay, very good. Okay, fine. Okay, so here once again the angio coming from crossover. You can see already relatively small arteries. He's in fact really also a very small man, and I would say maybe 4 millimeter arteries. Proximal maybe not so much calcified, distal somewhat more calcified, as you can see here. And this is also where the occlusion is. So it's a very distal occlusion going into nearly P2 segment. Because of this, maybe, and also because the arteries are very small, maybe not a good case for direct stenting. So clearly, we'll try here to come along with ballooning with drug-coated balloons. Outflow is okay. He has 3-vessel run down, anterior maybe very small distally, but posterior is very nice here. So we started here to try to get the wire through, and we actually started with an 018 wire with a command 18, which is somewhat, I would say maybe a little bit somewhat our standard wire here to approach these lesions. Hopefully that will run here now in just a moment. Okay, so as you can see here, first centimeter is not so difficult, and actually also went into one collateral, so maybe a good sign that we are somehow interluminal, but of course at some point if the lesion is long, risk is high that you land somehow subintimal, as you can see here, trying to loop here, or starting to loop that wire. And we changed then also to a quick cross support catheter and pushed that loop down. Sorry, unfortunately the machine did not catch that, I think. Didn't catch the loop here. But we had difficulties to re-enter, which is, I think, easy to understand because here it's relatively calcified. So here we changed then now to a CTO wire. So before we take re-entry devices or go retrograde, that would always be our first step. This is a Connect 250T. You can see here that helped us to redirect the wire into a better position directly to the plug. But also then we had difficulties, and we changed C-arm position and tried once again, and we're very close to the distal open artery. And you can see here that then was actually at some point, sometime, relatively easy to get that quite stiff wire through. So that's what we have done now. Maybe like to discuss here one point. So here you can see once again the lesion, very small distal. And here's some calcium, especially proximal and distal. So what do you think? If you see here now the distal portion, would you be happy with this? I mean, we were going around, sorry, I tried to show you here that magnified, going around here, that plaque distally, probably re-entered maybe a centimeter or 1.5 distal to the reopening of the artery. Yeah,
but however, always we are going some way around the plaque.
So, I don't know. So if I would plan to do atherectomy, maybe I would try to redirect the wire, maybe go retrograde and try to somehow take the wire into the true lumen. On the other hand, I mean, there's obviously very often no way through the calcium, but just around, and that's also what happened here. So what do you think? Would you be happy with this or restart here?
I think the one challenge, Andre, is as you mentioned to begin with, is this pretty small vessel that you're trying not to stent. When you get around that plaque, it's a little harder to think that you're going to come up with a strategy that you won't need a scaffold there. You can DCB and add a Sapera, but it'll be a pretty smaller Sapera. So it is a little challenging of whether you'll be able to complete this procedure without a needed scaffold if you continue down this road going around there.
So, Andre, I think understand the strategy here is to try to stay with the drug-coated balloon as much as possible and avoid an implant, right?
Yes, correct. For this, we will take now down here a scoring balloon, Headstart. This is
that's maybe an
interesting
interesting question to the panelists. I mean, we learned, at least in some of the DCB studies, specifically in the Levant studies, that the small arteries actually did have a not as favorable outcome. So based on that, do we have any specific strategies? I mean, here we see Andreas going for scoring, focal force balloon. Would anybody employ a different strategy here?
Zwei?
I don't think there's any data to guide us in terms of one therapy over the other, but I do think it's certainly been observed over multiple different treatment modalities that smaller arteries do tend to do worse. That's true with stenting, it's true with DCB.
So in other words, I mean, atherectomy, would a small artery be more an indication for you or less of an indication?
I wouldn't say it'd be more of an indication for atherectomy, but I'd be more inclined, because I expect higher potential for failure, I'd be more inclined to leave an implant that would be harder to retreat. So essentially, yes, I'd probably be more inclined to do atherectomy in those cases for that reason.
But once you've gone subintimal, you'd be less inclined to do an atherectomy than when you think I would.
Not necessarily. I mean, if you're using directional atherectomy, especially if you combine it with IVUS, you can kind of get a sense for where to direct those cuts. I'd be a little less excited about doing orbital or rotational atherectomy with subintimal dissections.
So just to remind the audience here, you all have these little instruments in your hand. There is actually a Link Mount Sinai app available in the App Store, so you can download that. This should be for free. I hope the internet connection is good enough here in the room. And then you have the ability to send questions directly here. I have this iPad. Sometimes it works. So if you are lucky, you can place your question here, and we can directly address it. So
Andre, which scoring balloon is this, and what size and length?
Now that was a 4 by 100, but this is actually what we are currently using, not the scoring. As you have seen, hopefully, we were not able to take it down because of friction of that balloon. So therefore, we pre-dilated now with a below-the-knee balloon, 2.5 120. And now we try once again to take the 420 scoring balloon down again. It tracks over an 014 wire, which of course sometimes is a little bit difficult in SFA lesions.
And Andre, you are
We have our
Andre, you are evidently partially subintimal. What is the role of the scoring balloon in such a case? If you are not,
well, yeah. That's a good question. I think I'm just partially subintimal. Again, here we have problems. And I mean, will the scoring balloon still be effective to somehow crack the plug, give me a bit, make it easier to open that plug? I think yes.
but if you are inside, but if you are subintimal, but you are scoring.
You mean if you're at least score to one side? I think it's extremely hard to be through the plug all the time, especially if it's very calcified plugs. I think in most of our cases it will be impossible. And therefore, of course, there would be little place for many of our instruments like scoring balloon, atherectomy, and total occlusions with calcium.
I go up very slowly.
So, Dirk, I have a question for you. Can you compare some of the economic issues in Germany, for example, to the U.S.? You know, right now we're still not under much pressure economically to limit the devices and so on. I think that there are certainly some centers are, but by and large, many of us are allowed to do whatever we want and use as much equipment as we need. Are you under, in your setting, is it different? Are you under increased pressure to be economically constrained, I guess?
I think there are probably significant differences in the reimbursement system. We are essentially paid on the DRG system, so we have fixed amounts for certain groups of procedures, and but we have, for instance, in Germany, the liberty that drug-coated balloons are reimbursed on top of the DRGs, which I think currently gives us also a good flexibility of using DCB and potentially in combination with atherectomy, which goes into one DRG, or with stent treatment, which would go into another DRG. The only thing you cannot do is using all together. So atherectomy, DCB, and stent, that would be an economical disaster. I would say at the moment we have reasonable choices, but for instance, drug-eluting stents are not really reimbursed on top of everything, which I don't think is fair to the technology. Well, anyway, I think we need to make choices. Probably we cannot do just everything in one procedure. But let's say an approach like here with a scoring balloon and DCB that is actually covered.
So I think as we get squeezed here, I think there's going to be a greater emphasis on being economically prudent, and I think that there will come clearly a time when we will not have those same types of choices, and we will in fact have to be more cost effective.
Mike, that time can come very quickly if your healthcare system goes through a merger. I'll just say.
Dirk, out of curiosity, is there any change in or any discussion of changing the reimbursement for DCBs in Germany as a result of the controversy around paclitaxel?
Well, luckily not yet. I mean, normally insurance companies are always jumping on these discussion points and trying to not to pay our bills, but I haven't heard about this in a larger scale until now. But I think everybody's a little bit looking at what happens here next week, and you know how the overall view on that develops worldwide, and be sure our competent authorities will react also as a fast follower. I could imagine
how many eyes are on one meeting as a result of one paper. It's interesting.
Although PCR basically said that you shouldn't change your clinical practice. So.
Yeah.
So, Andre, I think we have here some technical issues which we may want to take a few minutes to solve with the transmission. Okay, now we see an angiogram.
Yeah, an angiogram which well, doesn't make me really happy. So, what are your suggestions? Can you hear us?
Yes.
There's a beautiful re-enter with the Bollier technique.
Yeah.
Yeah, I think that's as you expected,
but
this
I think-
eccentric re-entry,
Yeah.
and probably have to do something in that particular region to optimize
Yeah.
the situation now.
Andre, how long was your balloon inflation? Do you think it's worth going back in and doing a prolonged inflation? I think it might be tough to fix that, but do you think that would
It was,
work?
I would say it was medium long, maybe not 2 minutes. I think we spent here, nearly 3 maybe. Seeing this, actually, I don't think we'll have better results when we try prolonged, maybe short focal, higher force ballooning. I wonder how it would look like if I would have, maybe passed that plug more precisely, not with the Bollier technique, 1 centimeter to distal, as Giancarlo said. I don't think it would look very much different. It's just a small artery with plug. Shall we take a 5, kurz?
Hatte keinen Schmerz, können wir schon machen, ne?
Okay, yeah. What do you think? Of course, in this kind of case, it's very difficult to come along without stenting. Nevertheless, due to the fact that the artery is very small, I will try a little harder maybe to do this, maybe to upsize the scoring balloon. Let's take a scoring 540. Okay, so we'll take some more time to work on that lesion.
Yeah. Andre, maybe we just go on here with a couple of talks, and then we come back and see where you are, okay?
Andre, you are live?
Yeah. Yes, Giancarlo, can you hear us?
Yes.
Okay, very good. Okay, so this was after the 420 scoring balloon, definitely not very impressive. We took actually a shorter 540 scoring balloon down here at that severe plaque, but also ballooned a little higher up with the scoring balloon. After that, I would say maybe more acceptable, but clearly not very nice. I think not only at that plaque where we passed that plaque with our wire, but also more proximal, where actually in that area I think we were still, that was at least my feeling with the wire, not subintimal, but who knows with our drivers. And then we took 520 for a really long time now in another Stellarex. This is 520 in different angulations to see that the balloon would fully open, and another 520 Stellarex, and this is here the result after that. Definitely better than in the beginning. So what do you think?
But now you need a
Potentially
stent.
some more post-dilation?
But now you need a stent.
I don't know. Yeah, of course. It doesn't look very nice, but
So-
at the end, it's very distal. So
Andre, would that be a case, given the small caliber of the arteries, where, for instance, a very focal scaffolding concept with a TAC device would have potential value versus using longer stents?
yes, that could be a solution. Not sure whether a TAC would be a good selection for that calcified plaque very distal, but let's say, for example, for the mid portion, no calcium there, quite some dissection. So I personally, first, relatively young man, very small arteries, first time here for treatment of claudication. I actually wouldn't like to directly take a long stent in here. We know that especially these distal stents can really make problems, especially if it thromboses up. So either maybe TAC, as you said, Dirk, or wait if it remodels, very nice. If not, if restenosis, maybe a good case then for an atherectomy to try once again to come along without stenting.
But this is a very, very impressive decision because you have also a very clear proximal recoil of the occluded segment. And you have to go back also in the proximal part. And they reconnect. And
I would take a bigger
just to
balloon there
discuss,
now.
it is possible to accept the risk of reocclusion before you implant a stent in this small vessel. But you have to be nearly sure that the probability, oh no, you're not sure, but the probability to have a reocclusion is not low.
Yeah.
So, Andre,
You're right.
what's the plan?
But again, I would-
Finish with this, or do anything more today, or how would it be your approach for the follow-up here?
Yeah, so we probably would take maybe a little bigger balloon, shorter balloon, to postulate that areas which still show some kind of recoil. If it doesn't become worse than now, as this year now, I would not take a stent in and see how it develops over time. So I think for that transmission, maybe we are finished. We just do some postulation here.
Also, that may not look like the absolutely perfect solution. It is probably as good as it gets, and I see that there is some agreement here on the panel also to follow that strategy. So I think with that we finish this case, and I probably suggest we take about 10 minutes break to get a supply with coffee and so on, and then we reconvene here.
Thank you, Andre.